This patient was treated with bendamustine and rituximab, but unfortunately 18 months later he presented to your clinic with weight loss and fatigue. You evaluate him with imaging and you find out that he does indeed have progressive adenopathy, suggesting recurrent disease. One thing that's not pointed out in this case is whether or not he had an additional biopsy, and I'd like to make that point that particularly in patients that have short remission durations and patients that have symptoms, possibly B symptoms, is not completely clear here. We typically try to rebiopsy and make sure there hasn't been transformation to diffuse large B-cell lymphoma. That would have a very different treatment algorithm than a grade 1-2 follicular lymphoma. Nevertheless, this patient was treated with R-CHOP, and it appears that he received 2 cycles, but unfortunately had complications of symptomatic anemia. This patient did achieve a partial remission apparently to 2 cycles of R-CHOP, but really didn't tolerate it very well. So a couple of points regarding that. It's pretty unusual to not tolerate R-CHOP. So I would probably evaluate this patient's bone marrow. Does the patient have MDS? Is there something else going on? This history of CMV also is a little strange in this case. Does he have some other immunodeficiency that's further complicating this patient's therapy? So quite unusual for a 62-year-old, otherwise presumably healthy, to not tolerate R-CHOP. At every relapse of follicular lymphoma, we always ask the same question: does this patient require therapy? Because we can still have prolonged periods of watch and wait, even if we know patients have relapsed. And I know we've all had in our clinics patients who we know they've had recurrent disease, but they're asymptomatic, and we can watch them for many months or even years. This patient appeared to be symptomatic with fatigue and weight loss, and it does appear that there's an indication for treatment. The other question that comes up, and we know more about this now, is what is this patient's prognosis? We were able to prognosticate to some degree from the FLIPI score at the beginning, but we actually have a better bit of predictive data now based on the short remission duration. There were some very nice studies done from Dr. Casulo and colleagues looking at early relapse, and she was able to show that patients who relapsed within 24 months of their initial chemoimmunotherapy, with the caveat that not many patients had bendamustine and rituximab in that data set, had a very poor prognosis. Their median survival was only about 5 years. Unfortunately, this was only about 20% of the patients, and about 80% did well. And those who didn't relapse within the first 2 years did very well. And other subsequent studies have shown that this population has survival similar to age-matched controls. So we learn a lot about from the initial remission duration in terms of what we expect to happen in the future. 80% of the patients will do well. Those are the ones where we really want to have restraint. We want to not over-treat those patients, treat them with probably gentler therapies. And for the 20% who have early relapse, those are the ones where more of the same is not going to solve the problem. This gentleman's now presumably only about 63, 64 years old, and with a 5-year survival, that's not anywhere close to the expected survival for this patient. So in these patients, we often think, or I think most of us in the field say, we need to do something different. We offer a clinical trial, novel agents, think of high-dose therapy and autotransplant, maybe even think of things like CAR T cells. These are the kind of the discussions that we have with patients with these early relapses. We don't know what the exact right answer is, but we know that more of the same does not lead to good outcomes. The choice of R-CHOP in this patient was reasonable, but I probably would not use that as a standalone. I wouldn't expect to get much remission duration unless there was a suspicion of transformation out of R-CHOP, having only got 18 months out of bendamustine rituximab. In a 63, 64-year-old patient, are we going to consolidate that R-CHOP now with an autotransplant, or is there some other strategy to try to maintain that remission? Another unusual point of this case is that the patient developed anemia after R-CHOP, which is not a major problem typically with R-CHOP. So I would investigate that, potentially look at we don't have any other comment on the other cell lines in terms of thrombocytopenia or neutropenia, potentially look at his bone marrow, make sure he doesn't have some early MDS. But other than that, we often would just transfuse patients to support their anemia.